Happy last Thursday of July, everyone. My name is Lourdes. I am so grateful that you are all here with us today for our webinar. I want to just make sure that you have this reminder to please put any questions that you might have pertaining to this webinar into the chat or the Q&A. Please make sure that these questions that you have for our speaker are general in nature and not specific medical questions, as she will not be able to answer your specific medical questions. With that, I want to introduce our speaker for today's webinar. Dr. Louise Connell is a medical oncologist at Memorial Sloan Kettering Cancer Center. Experienced in caring for patients with cholangiocarcinoma, Dr. Connell is a leader in HAI therapy, a regional approach that she incorporates along with systemic chemotherapy in her practice. Thank you, Dr. Connell.
Thank you, Lourdes, for the kind introduction, and I appreciate the opportunity to speak to you all today. I'll briefly go through some didactic slides, and then after that we'll get on to the question and answers. So to just give a general overview about the role of HAI therapy in intrahepatic cholangiocarcinoma, hopefully you can all see my slides okay. Okay, so this is just the quick disclaimer. And then to talk about intrahepatic cholangiocarcinoma. So intrahepatic cholangiocarcinoma affects approximately 4,000 to 5,000 patients each year here in the United States. And what's important to remember is that only a small proportion of patients can be resected. So it's approximately 1/5 to 1/3 of patients. Even in patients who undergo a curative resection or surgery, there's a very high rate of recurrence, which can be up to 60 to 70%. And what we've learned is that control of disease in the liver is associated with improved survival for patients. So what is HAI, or hepatic artery infusion therapy then? So I have a little graphic to show how the pump works. So the hepatic artery is the blood vessel which supplies blood to tumors in the liver. And if we look at traditional chemotherapy in the management of cholangiocarcinoma, it's delivered through a vein. The drug travels through the body's bloodstream to reach the liver, and only a small portion of the drug will ultimately reach tumors in the liver. What's also important to note is that there are systemic side effects, in that the side effects from the chemotherapy are felt throughout the body. How does HAI therapy then compare? So with HAI therapy, it's delivered through a pump which is implanted below the skin in the abdomen. And you see this in the graphic here. We describe it as being like a hockey puck. And I always find that when patients come to see me in clinic, it's important to show an actual pump model so that they understand and get a sense of how the pump feels and looks. The drug is administered through this hepatic artery directly to tumors in the liver, and it treats the entire liver. With this method, we can achieve anywhere up to 400 times a higher drug concentration in tumors in the liver, and there are limited side effects elsewhere in the body. So we're really looking at the main two side effects we look for HAI are looking at liver enzyme function and adjusting dosing according to that, as well as from very early studies, we saw a slight increased risk of some ulceration. So all of our patients are on medication to help protect against ulcers, but really no systemic side effects. So the Intera 3000 HAI pump then is FDA approved. It's about the size of your palm. And it's powered, basically body heat is what powers delivery of the drug through the pump. The therapy in the pump flows continuously and directly to the liver, and patients can continue their daily activities. And I'm sure this is something that may come up in the question and answer portion of the section, because there's often many questions for me about limitations on daily function in patients who have a HAI pump. The pump is refilled every 2 weeks during active treatment. So what is it like as a patient then? So if we follow the model here, we see up the top, so that it starts with a consultation with the HAI provider to learn about the therapy requirements and also your eligibility for this particular treatment. The patient will undergo scans to rule out cancer spread outside of the liver or to other areas, and also confirm eligibility for the procedure. And what that means is we do a particular type of scan, which is called a CT liver angiogram. And we're looking at the blood supply into the liver to understand how the anatomy is in order for the surgeon to place the HAI pump. The patient will require stopping chemotherapy for about 3 to 4 weeks before any surgery. And then a surgery is performed to implant the HAI pump. And while you're in the hospital, there will be a flow scan performed to ensure that the system is functioning well and all confined to the liver. And after this special flow scan is performed, the pump will be filled in the hospital prior to discharge. So there's a small stay in the hospital. And then you're after discharge from the hospital, you can have your first HAI pump refill at 2 weeks from surgery. So typically what I do at that visit is I try to combine the visit with the post-operative follow-up with the surgeon. And I also get patients a new CT scan because you've had this period of time off chemotherapy to allow the surgery to take place. And then I arrange for the first dose of the liver drug, the floxuridine, to be given at that visit. A patient will return every 2 weeks for lab testing and pump refills, and it alternates between the active drug, which is floxuridine, with heparinized saline. What's important to note is that if you can't attend a refill appointment, you need to call your HAI provider so that the pump doesn't run dry. And also what I always say to my patients is, things happen and sometimes appointments need to be changed. But it's very important that if you can't make it back to your refill appointment with the drug still in your pump, that we get the drug removed either on the day expected or a few days early. So we don't like the floxuridine staying in the pump longer than 14 days. So if you can't make it on time, it's better to come early and get the drug out a day or two early. Systemic chemo is not started at exactly the same time as the liver drug treatment. It's typically restarted around 4 weeks after surgery. And then that continues as it would have previously every 2 weeks. And there's continued follow-up with the HAI provider to monitor response to treatment. So typically what I do is I scan my patients with a CT scan every 2 months. So after every 2 doses of the FUDR to assess response. During the HAI therapy, again, it's important to inform your provider if you're going to travel or any activities that you have. And then based on response to treatment and tolerance, it's up to the provider to determine when to discontinue the treatment and also how to maintain the pump. So once you're not receiving active treatment through the pump, if the liver enzymes are under control, we can put another substance into the pump called HAI glycerol, and this requires a pump fill every 8 weeks. So again, that's often a question that comes up: is what is life like after chemotherapy with the HAI pump? It's every 2 months to get a glycerol fill. So who are the types of patients then with intrahepatic cholangiocarcinoma in particular who can benefit from HAI therapy? So if we're looking at the characteristics for the patient themselves and the tumor, at the current time, it's used in patients who have unresectable intrahepatic cholangiocarcinoma, so not operable at the current time. Often there's large, bulky disease or volume of tumor within the liver. There's stable disease in the liver, potentially in patients during treatment with first-line systemic treatment. The patients either have no evidence of tumor outside the liver or very limited tumors outside the liver. So for example, if there's a little lung nodule, but the bulk of the cancer is within the liver, and maybe we can, ablate or radiate the lung nodule later on, a patient like that is suitable for a HAI pump. And also what's important is that there must be adequate liver function. So we do look at the liver enzymes prior to starting treatment to ensure that you will tolerate this treatment. The goals of the treatment, then, we talk a lot about disease control and durable response. So the idea is to control disease within the liver and to prevent any further spread of the cancer with long-lasting response to treatment. Often in patients, what we see is an improvement in the liver function, which helps patients over time. And therefore, there is evidence that the HAI therapy can improve survival in patients with cholangiocarcinoma. So then I just have 1 or 2 slides going through, what is the clinical data, because I know many of you are so informed and often come to me in clinic and already have this information. So There was a systemic review then of 9 publications that was published in the Annals of Surgical Oncology back in 2022, which looked at 154 patients. And what it showed is that HAI therapy was associated with a substantial improvement in survival for patients with intrahepatic cholangiocarcinoma. And if you look over on the left-hand side, you'll see a clear difference in the bar chart. So the purple is the HAI with systemic chemo, and these patients had 39.5% 3-year overall survival, as opposed to a very, very tiny percentage of patients, less than 3%, with a 3-year overall survival getting systemic chemotherapy alone. And at the time, that was patients having gemcitabine and cisplatin. That was the comparison. It did not include patients receiving immunotherapy drugs. But, to summarize this, there was a substantial, almost a tenfold increase in 3-year overall survival with the use of HAI therapy in combination with our traditional systemic chemo, as opposed to the standard treatment at the time, which was gemcitabine and cisplatin. So there's been a barrage, I would say, of new trials since then, and a lot of enthusiasm around HAI therapy. And on the left-hand side, what I'm showing is 2 studies which look at HAI in cholangiocarcinoma. And then on the right-hand side, you'll see 2 studies which are really looking at immunotherapy with systemic chemotherapy in intrahepatic cholangiocarcinoma. So going through the first one then, so the PUMP2 trial was presented in 2024, and it was presented at one of our big meetings at ASCO GI in San Francisco, and really garnered a lot of interest from peers and from patient groups. And what this study showed was that with HAI therapy, there was a significantly greater median overall survival of 22 months as opposed to 12 months in patients who received gemcitabine cisplatin on its own. And highlighted at the bottom here, you can see that the 3-year overall survival was 33%. So that's pretty similar to what I showed in that retrospective review of other publications. Also, I think what's interesting to note about this study is that it was a study that was performed in the Netherlands. And this also showed that there are now increasingly more centers using HAI therapy successfully. The second paper then, or the second study to highlight, was published by our own group here at Memorial. And this was a retrospective study published by Darren Kauser back in 24. And this looked at HAI therapy in combination with gemcitabine oxaliplatin. So at that time, we were using oxaliplatin as our platinum drug. And here we saw a median overall survival of 26.8 months. And so highlighting at the bottom here, you can see it circled. The 5-year overall survival in this patient group was 21%, which is really good. In comparison then to these HAI studies, we see 2 studies, and you all have probably read about this and are very familiar with them. So we have the TOPAZ-1 trial, which is now our current standard of care in terms of systemic treatment, and that's the gemcitabine cisplatin, which we've been using for a long time, in combination with durvalumab, which is an immunotherapy agent. And here we see an increase in survival from 11.5 months to 12.8 months. And it's always important to say that you can't really completely compare across different clinical trials, but this was a 6-week difference in survival by adding the immunotherapy to the gemcitabine cisplatin, as opposed to what was seen with the PUMP2 trial, the first one I showed. That was a 10-month improvement in overall survival. And then the other study to mention is the Keynote 996. And this is also another immunotherapy-based study which used the drug Keytruda or pembrolizumab, again in conjunction with gemcitabine cisplatin. And the improvement here in median overall survival was 8 weeks by adding in the immunotherapy agent. So with a HAI education specialist, then you can contact them to get information and also to connect you with a HAI provider. So what this is you can, and if you want to take a picture of the QR code, you can submit an online form to a HAI education specialist from Intera Oncology, and then they'll answer the questions that you have about HAI therapy. We'll also help navigate you through some of the conversations that you would have with the physicians, connect you to a HAI provider near you for an appointment. And in the time period that I've been here doing this, there really has been a huge surge in the number of HAI providers across the country who are gaining a lot more experience in regularly treating patients with this therapy. And also, with the HAI education specialists, they can provide education and support as you begin to consider HAI therapy. This is just some safety data then to highlight. So the pump is specifically to deliver medications such as chemo to the blood vessels in the liver. With any medical procedures, there can be risks, which would be explained to you by the surgeon prior to pump placement. There are some special care requirements, which I'm sure we'll get into with the Q&A session, but scuba diving is a hard no. I say that to my own patients. Also, during the period of time that you're on active chemotherapy, anything that heats up the body, like hot tubs, saunas, and because the concern there is that it's heating up or speeding up the rate of infusion of the FUD or the active drug into the liver. You do have to be mindful when you're traveling, but the honest answer is most patients travel by plane to get to me for HAI therapy, so you can travel, but be mindful of high altitudes. And also if you have a fever, because again, a fever is increasing body temperature. So what may happen is that the drug or the rate of the infusion speeds up, which can be more toxic to the liver. Or the second issue is that if there's speeding up in the rate of infusion, the pump itself can run dry. It's always important then to talk to your doctor if you want to fully understand the risks and the benefits when using this device. So that's just a short didactic section, and we'll get on to the Q&A. So I'll leave it to Lourdes to
Yeah,
start.
perfect. There are a couple of questions that have come in. Some I think you have answered, but for example, if the pump is implanted at the same time that there's the removal of the tumor, will the chemo be added then to the pump, or will one wait the 2-week period of time? So is the pump filled once it's placed?
The pump is filled once it's placed. What's important to clarify at the moment is the indications, right, for using the HAI pump. So we use the HAI pump in colorectal cancer, and we also use it in cholangiocarcinoma. In colorectal cancer patients, we are using it after resection of tumor in the liver. In cholangiocarcinoma, at the moment, we're not using it in patients who can have an operation on their liver. So we're using it for patients who are currently inoperable to try to improve disease control, improve survival, and potentially convert some patients to surgery. I can see a question at the bottom about operable. To add on to that, we are deriving a clinical trial protocol to explore the use of HAI therapy in patients who in what we call the adjuvant setting, so can have surgery on the liver, and using it in the preventative setting after surgery. But at the current time, that's not what we're doing. So if a patient is having the pump placed on its own, but not having liver resection or an operation, which is what's happening at the current time, you can give the active drug, the FUD, at 2 weeks and start the regular systemic chemo, such as gemcitabine-based chemo, at 4 weeks. In a patient who has surgery on the liver, we delay that a little bit, but we're not currently applying that to cholangiocarcinoma. But watch this space, I would say.
Okay.
Yeah.
You mentioned 60 to 70% regarding occurrence rate for intrahepatic cholangiocarcinoma patients. Does this percentage change after the pump?
Yeah, so what's important to note there is that the recurrence rate, the majority of patients, the recurrence is within the liver itself. The issue at the moment, or not the issue, but what's important to acknowledge is because we are not currently using HAI therapy as adjuvant or preventative treatment, I can't tell you that the pump reduces that risk by a certain amount, right? Because we're not using it to reduce risk of recurrence. That's where when we begin to use the pump as adjuvant therapy or after resection, we'll know more about those statistics. What we do know is that in patients who have recurred or within the liver, or who have inoperable disease to begin with, we are improving outcomes for those patients by placing the liver pump.
Can you have HAI therapy without systemic therapy if you have no cancer outside the liver?
Yeah, very good question. So the honest answer is that, this treatment has been developed to be given in conjunction with some form of modified systemic chemo, right? So in general, I can probably name a handful of patients where I've given it on its own. we know that by giving it in combination with some systemic or traditional chemo, we can improve response rates within the liver, number one. And also we want to make sure that, yes, we're treating the liver, but we want to prevent any signs of spread of disease outside the liver. So it's a very, very select group of patients where we would use the pump on its own. And I definitely don't want to say that that's sort of the typical approach. What I have found is, because often what happens for me here is, as I said, the patients travel to come and see us. So they see myself and the surgery team the same day. And understandably, patients come in to me and they think, yes, I'm going to have the pump and I'll get a break from my regular chemo. So I'm always very mindful to say during that consultation that I will give some traditional chemo with the pump. What I have done in some patients is if, for example, we get very good response in the liver by using the pump with traditional chemo, and I want to scale back the chemo or put them on a maintenance chemo, I may then stop the systemic chemotherapy after a period of time and just keep them on the pump treatment. But again, that's a very, they're very individualized cases. It's not the standard from the get-go.
Okay. Can you share a little bit about exclusion factors? For example, if it has spread to the peritoneum, is someone still eligible for the HAI pump? Or if the location of the tumor is close to the inferior vena cava but not growing through the liver, is that is that an inclusion or exclusion factor for them?
Yeah. So to answer the first part first, if somebody has peritoneal spread, the honest answer is, a HAI pump is not the right choice for that patient. The concern being that even though we recommend, and I recommend continuing some form of systemic chemotherapy with the pump, the dosing is modified and there definitely are drugs that can't be used. So at the current time, we don't have safety data, for example, to use the immunotherapy drugs. So your durvalumab with gemcitabine with cisplatin with the pump. So I wouldn't include that. But if there's a very isolated, like a small lung nodule, we have shown that if there's very small volume lymph node involvement, for example, those patients still benefit from pump treatment. But I would be very cautious in a patient who has peritoneal involvement or like bone involvement, for example. Again, I can also see patients who, for example, may be potentially further into their cancer treatment, right? And they could have an isolated bone metastasis that has been stable for a year, so that would be an exclusion criteria. With peritoneal disease, again, I would say it's very rare that we would do so. But with a very informed discussion with the patient and honestly presentation of the case at the tumor board, which I think it's what is needed at an expert center to make sure that it's the right decision for that patient. We've done so in some very select circumstances, but again, it wouldn't be the typical approach for patients. Yeah.
Okay. Is this the same drug as a 5-FU?
So it's a prodrug of 5-FU. So the floxuridine is a prodrug. And the reason that we use the prodrug has to do with the first pass metabolism through the liver and the higher concentration. But it is similar to 5-FU. So on that note, often I'll have patients who come to see me who perhaps had regular 5-FU, right, systemic 5-FU. And if the patient has had issues on 5-FU, for example, like coronary vasospasm or any of these other systemic side effects, a question that's often asked to me is, is that patient safe for the FUDR, right? Because it's a derivative of the 5-FU. And to answer that question, I would not expect the patient to have the same cardiac or coronary issues from the FUDR, but I would also be conscious that perhaps they're a little more sensitive to the 5-FU. So what I've done, and I've certainly had patients like this come and see me, is I may start them off on a slightly lower dosing of the FUDR to see how their liver tolerates it. And then after 2 rounds of treatment, I'm scanning the patient. And if they're tolerating it well and responding well on the scan, I may then escalate the treatment. So I don't expect to see the same exact same side effects that a patient may have experienced with 5-FU, but I would be cautious that they may be more sensitive in terms of the liver tolerance.
Okay.
Yeah.
Can a general medical oncologist fill the pump. So this person lives 2.5 hours away from where the pump is being placed. Is that something that can be done?
Yeah, so I think increasingly this is possible to do. I think a big watershed moment for me, at least, was the COVID pandemic, and we had so many patients who were stuck in different parts of the country, and it was very, very hard to get patients, pump fills, and it was a very challenging time overall, I would say, for everybody for many reasons. But I felt it very strongly for my patients with pumps because it was just so hard to do so. So if there is enthusiasm from the local oncology office. And I think it's not just the medical oncologist, to be fair, it's the nursing staff, the pharmacy there. Then there's a huge drive by Intera to help educate and train patients or their providers locally. I think increasingly we are finding centers that are able to do this. I think a lot of it, to be fair, comes down to the nursing staff. And educating nursing staff. So on that regard, here at Memorial, at least, I have medical oncologists who come and observe in my clinic, just to see how it all flows. And we also can help set up, nurses to come and see our infusion nurses, access the pump. But it's become increasingly, possible to do. The other important thing to mention is that there's also a company called Pentec in many states in the US. I don't think in all states they can do it yet, but they can also help with home refills for the pump. I'm not currently using it here in New York, but I know that it's possible around the country in various different states and has worked very successfully for many patients.
Okay. Can durvalumab be provided by the pump rather than systemically?
Not yet. Not yet. I think this is a big question when patients come to see us, honestly. I know there are a few different efforts around the country looking at this. I think it's, the next step in how we treat patients. And that's why even in my slide, I'm mindful of saying don't cross-compare across trials. I definitely don't want to say that immunotherapy adds no value in patients with cholangiocarcinoma. It certainly does. But I think at the current time, we don't have safety data to either combine it with the pump or put it through the pump. We do have a current protocol here of pump treatment with regular chemo that we are going to amend to include immunotherapy in it. So I think there's more to come there. Having said that, if I see a patient, for example, who comes to me and has very bulky liver disease, but maybe has some more extrahepatic disease, I do give them upfront gemcitabine cisplatin, and I use durvalumab just as a bias, but pembrolizumab is also fine. Also, what can be done is if a patient presents with liver-only involvement and therefore is a pump candidate and does well on pump treatment, but later on perhaps develops any more progression or recurrence outside the liver, I've given immunotherapy later in those patients. I just haven't given it at the same time that I'm giving the active FUDR treatment. So the treatments can be used sequentially at the current time. They can't be given together, but it doesn't mean that you can never give them.
So at this time, the FUDR is the only drug that can go into the pump. Is that correct?
So there's FUDR. There's also mitomycin as a second drug that we give. This is not used as commonly around the country. There's smaller data to support it. The study that I showed from Darren Kauser on that slide that was published in 2024, he did present some data with the mitomycin drug. So where do I use that? So I might use that in patients who've had a very, very good response to the FUDR treatment. And then we begin to see signs of progression in the liver, but they have responded to the liver drug to begin with. And again, these patients would have liver confined disease at this point in time. If the patient's liver function is still good and under control, what I've seen is added benefit by combining this mitomycin drug with the FUDR. The mitomycin is also given once a month. It's not given every 2 weeks. The difference is that the FUDR is given like a little injection. It's like a 20 cc syringe. It's very quick. The mitomycin is given as an infusion into the pump, and the patient lies flat. So it's more labor intensive and requires more expertise as well. It's a little more involved. So I have used it in patients, but we have more retrospective data in that regard as opposed to the prospective data. If a patient has progressed very quickly on the FUDR, I would not recommend moving on to the mitomycin. We're not helping a patient by doing so.
Okay. Can you share why extrahepatic tumors are not eligible?
So I think what's important there is the concept about, what's driving survival for the patient and also getting control. So I think if there's very limited disease outside the liver, and the patient has bulky liver tumors, we know that we're helping that patient and we're improving outcome. If a patient has more widespread cancer throughout the body, the issue is that we have to modify the systemic treatment, right? And so they're not getting as much through the whole body. And for example, you at the current time you can't. We're not giving the immunotherapy arm, for example. So it's really about the systemic control that's there. Whereas if somebody has a limited lung nodule, you can go in and ablate that. So it really has to do with the volume of cancer outside the liver and making an informed decision for that patient.
Okay. Are there any stage limitations? So for example, only stage 2 or only stage 1 patients?
No, so at the current time, it's technically what we would call, stage 4. So they're locally advanced but unresectable disease in the liver. We're not using the pump in early stage or resectable tumors up front. And also, I think I forgot to answer one of the questions earlier was the question about, involvement of the vena cava or the degree of involvement of the liver. So that does also factor in. What we have seen is that, one of the ways that the liver pump has helped patients in terms of improving survival is getting better control. And one thing that I say to my patients is if there's signs of pressure on the vena cava, on the bile ducts, on the blood vessels, or there's elevated liver enzymes, what I've seen is even in advance of scans, if they're responding well to the pump, what I see is I actually see the liver numbers improve first, even ahead of cancer markers and ahead of scans. However, if a patient has like a portal vein thrombus, has very extensive tumor within the liver, and what I mean by that is almost, the full liver is replaced by tumor, or has signs of back pressure like portal hypertension, they're not able to process the drug, and so there is a limit in that. But bulky bilobar disease is eligible. Another area that would cause me pause would be if a patient has ascites or fluid within the abdomen. The concern in that regard can have to do with, the liver pump is in the abdominal wall, has to do with, infection risk, right? Dealing with ascites in the abdomen. And then the other question that often comes up is, I mentioned that high liver numbers, they get better. What I mean by that is the alkaline phosphatase, the transaminases. Bilirubin would give us pause, right? If the bilirubin is not due, a high bilirubin is not due to, dehydration or Gilbert's disease. If the bilirubin is high, 2.53, again, there's concerns in terms of a patient's ability to process the drug. Yeah.
Okay. Would a patient who had the HAI pump placed and has the tumor shrinks, would they still be eligible for a liver transplant, or would having had the HAI pump disqualify that?
Yeah, very good question. So having a pump does not disqualify you from liver transplant. I think liver transplant is something that's very in vogue at the current time in colorectal cancer, less so in cholangiocarcinoma, but I am seeing patients who are seeking opinion. We don't do liver transplant here at Memorial, but I do work with outside centers. The pump is absolutely not a contraindication. And often what we find is that it can be a good bridge to transplant. Obviously, I would work with the individual transplant team for any of my patients to go through the do's and don'ts and what they would like to do. But transplant evaluation is a long process. And so, the pump may be something to be considered in advance of that. I think, talking about liver transplant, that also leads on to other liver-directed treatments because this often comes up as well. So If a patient has an ablation or something like that, the liver pump, can be done after that. Where I prefer to use, what we know is that using the liver pump earlier on in a patient's cancer treatment, number one, the better at least the patient can tolerate the drug, and also the response rates are higher. So the earlier a pump is considered. If a patient wants to or is recommended by a local team for something like Y90 or other liver-directed treatments or radiation, in general, my preference and our recommendation would be to do the pump treatment first and consider these treatments later on. But having Y90 or having radiation, it's not a complete contraindication. Sometimes that comes up, a patient thinks they're ineligible because they've already had Y90. What we've seen now is that these procedures are becoming much more selective, the Y90, for example. So again, it's something that would be reviewed at our tumor board, looking at the extent of local treatment already on the liver, looking at the blood supply into the liver. And I certainly have had patients who have had pump treatment after one of these liver-directed treatments. My own bias, though, if I meet a patient ahead of that and they're deciding between the two, is that I generally prefer to sequence it with pump first and these liver-directed treatments later on.
Okay. And then does having stents or a PTC tube affect if one can get an HAI pump?
A stent is definitely a concern for a patient. The question is the rationale behind having the stent in place. I've done it in select patients, but it's something that would need to be reviewed at the tumor board.
If other local therapies, like you mentioned, TACE, Y90, are ruled out due to poor arterial supply, is there a benefit of using the HAI pump?
Yeah, very good question. Again, we would have to assess it and see. In some circumstances, it's still applicable, and in others, it's not. If really there is no good arterial supply there, but definitely if somebody has already had different interventions such as Y90 or TACE or that can affect the ability as well, and the blood vessel supply. It's also something else to mention in terms of because I see a lot of patients where it's pump first and then Y90 later on. So I've also learned that it's important to know when to pause or stop the pump treatment so that we keep the blood supply healthy, so to speak, for potentially a Y90 later on. And this is where, if I have patients who have done well for a period of time, I think one of the slides I mentioned, it's up to the HAI provider when to stop the pump, right? So you could be responding well, really have stable disease, there's no activity, the cancer marker has normalized. Will I take a pause in the pump? Yes, so that I can use the pump again later on. Or if a patient potentially needs another intervention like Y90 later on, I don't want to over-treat with the pump. So you can stop for good reasons too, that you've gotten a good enough response and you just want to invest in time off the pump so that we can use it again later on, similar to what we might do with some of our traditional chemo drugs as well.
Okay. How much of a risk is infection as opposed to a chest port?
So yeah, I mean, infection risk is super, super low is the honest answer. It's not something that commonly happens. We are mindful because, it is the size of a hockey puck, right? It's a foreign device in the body. So, we are cautious. Like if patients go for any sort of routine procedures, dental work, we will cover with antibiotics as preventative. If somebody has a fever, we check it out. But again, I have a handful of patients in the time period that I've been here doing pump treatment where an infection of the pump has been an issue. So it's really not commonplace, but obviously rare, but a serious side effect to watch for and to monitor.
I know you mentioned a couple of times about making sure that the pump doesn't go dry. Can you share what happens if that does occur?
Yeah, so when the pump is filled, there's always a little bit of a residual there as a sort of a safety mechanism for patients. So we always expect that when you come back for your fill, you'll have a certain number of cc's remaining, and that's sort of your wiggle room if anything happens. The issue when the pump runs dry is we want to keep the whole system patent, because You saw on the graphic earlier, from the pump in the lower belly up to the liver, there's a tube or a catheter. If the pump runs dry, the concern is that the catheter itself can block off. In some patients, what we may do is similar to what you can do with a Metaport, is if you're getting some resistance in the pump, our nursing staff can give the alteplase or the declogger to try to see if they can free it up. Or there's also a side device on the pump to check. But the concern is that we've really lost that connection to the liver. So there's always, it's typically around like 6 to 10 cc's residual in your pump, and that allows for this freedom in terms of if you're flying on an airplane and different things like this. I think where it becomes more important, honestly, is in patients when they have the glycerol fills, right? Because we all get comfortable, right, when we're taking a break in treatment, and it's just trying to maintain the consistency of follow-up. And that might be where, for a patient, having a local provider or having this Pentec service coming into your home, it helps maintain that. But again, these are not common issues that arise, but are important to be prepared for. I think what's important to mention in that regard is the difference between a liver pump and a Metaport. So if we remove a Metaport, we can always put another one back in. With the liver pump, because of the way that it's placed in the gastroduodenal artery to the blood vessels into the liver, really by removing the liver pump, we cannot place another pump. So in general, if a patient either gets to the surgery on the liver, which I have seen in patients with cholangiocarcinoma with pump treatment, or we get to a place where we've treated to maximum response and there's really no active cancer on the scan, we will keep the pump in place for at least 2 years and fill it with the glycerol, because once you remove it, it's really done. If a patient goes for liver transplant, the transplant team will remove the pump at the time of liver transplant. Yeah.
Okay, so in general, the pump is not removed if you just discontinue the treatment. It stays in for 2 years. We had a few questions about that.
Correct. And you get this glycerol fill every 2 months to maintain it. Exactly.
Okay. Can you share a little bit about how recovery from the pump placement looks like?
Yeah, so the honest answer is it's usually a pretty straightforward surgery. What I again, in cholangiocarcinoma patients, because we're placing the pump without operating on the liver at the same time, sometimes it can be done robotically. Some surgeons can do it robotically or laparoscopically. In other cases, it's an open surgery. But typically, patients may be in the hospital for 3 days because you do the surgery to place the pump. You get that flow scan that I mentioned the next day, and then we fill the pump. What I should mention is that in patients who have not previously had their gallbladder removed, even if we're not doing an operation on the liver, we will remove the gallbladder at the time of pump placement to prevent any issues in that regard with drainage and that later on. So you will have an elective procedure to remove the gallbladder at the same time that the pump is placed. What I say to patients, honestly, is that there is an adaptation after surgery to having the pump there. It can be a little bit swollen after surgery. A lot of patients are side sleepers. It's on the side of your belly. So the first 2 weeks, you're sort of learning how to live and sleep and move around with it. But the recovery from a surgical point of view is pretty straightforward. Sometimes when the pump is swollen, what can happen is there's a little bit of fluid in the pocket. We call it a seroma. And what happens is the nurses, when they're accessing the liver pump, they can just drain off the fluid if it's a lot, but most times it just settles back itself after surgery. But as I said, in these patients, we're ready to give the drug at 2 weeks, and many patients would be ready even before then. I think in that regard as well, just to mention, there was some data looking at this more so in colorectal cancer patients, but it does apply also to cholangiocarcinoma, in that most patients report feeling better on pump treatment than they did on regular systemic chemo. And the reason for that is, even though you're still getting the systemic chemo, it's modified. We don't run into the same issues with things like neutropenias and, the diarrhea and the nausea and the vomiting. So it's a very well tolerated treatment. And we have some data on this looking at how patients physically function and their quality of life. And it's shown that, in the vast majority of patients, they describe feeling better on this treatment. for those reasons. But there certainly is an adaptation to having it there to begin with, I would say.
Okay.
Yeah.
So we have a few viewers from Europe who are asking whether or not the pump is available in Europe. I know you mentioned there was that study that was in the Netherlands. If you see patients who come from Europe, and if you would recommend that long journey flight to the US from Europe to do this type of a treatment.
Yeah, very good question. I think a lot of the work from the Netherlands has really garnered a lot of interest. So I think there are, they have protocols at the moment for using the pump in these patients. For those reasons, because it's a newer treatment there, and regulations in the EU, in the European Union. Do I see patients from Europe? Yes. I see patients from further than that. I have patients who've come from Israel. I have people who've come from Canada. So patients definitely travel. Because I'm so passionate about the pump, I think I'm a little bit biased in saying I think it's worth the trip. But I'm also very mindful, honestly, if I'm bringing somebody all the way here for this treatment, am I really going to help that patient? And I think that's where being very honest with patients, if it's liver confined disease, going through a lot of that with the patient. But I have had patients who come successfully. We have worked with their teams closer to home. So I have 1 or 2 patients in Israel where, for example, we've helped with glycerol fills closer to home. The same in Europe, not the active drug just yet. I have a lady this week who's moving from the Netherlands to here because she doesn't qualify at this time for their protocol, but is going to come for a pump here. So when I'm talking to patients, I look at it in 2 ways, and I say this to them. I'm talking to you as if you live around the corner here, and yes, this is what I would do. And I also talk to patients understanding that you're traveling all the way here. And the honest answer is, if I think, for example, there's concern for portal hypertension or ascites, and I'm not going to be able to successfully give pump treatment, I'm not going to have that patient and their family invest in coming all the way here for that, and may well recommend another treatment like Y90, or if there's any signs of extrahepatic disease, as opposed to the opposite, telling a patient that I really do believe that the pump is going to help them. In Europe, you can tell from my accent, I'm Irish. So there are many Irish fellows who've been here, who've trained here. They are increasingly trying to bring this into Ireland as well. I think at the current time, at least from my understanding, it's the physician themselves who's accessing the pumps to do it. So I've seen a little bit of everything. I've seen patients where they've had the pump put in here, they've continued to fly here. We provide letters to help them with embassy and travel to come here. I've had patients who've gotten set up at home then maybe for the flushes, and also tried to help other centers as well.
Is there a way that patients can find providers or facilities who offer the HIA pump either here in the US, Canada, or Europe? Is there a way for them to do that?
Yeah, so on the Antira website, you can put in your location, and I know that they increasingly show centers that are available, and guide you on that. I think it's more confined to the United States than globally. The other important thing to mention is we can also do some remote consults for patients, particularly from other countries. So I've certainly done that, where maybe I've spoken to somebody in France or somewhere else in Europe, and before they invest in traveling all the way here to the US, is this something that I'm eligible for? And so I've set up, a remote consultation through our international center, sometimes with the surgeon on the same call, sometimes separately, and we have that discussion with the patient and family member. I have another patient I recently from Australia, same thing. We said now is not the right time, stay where you are. So there are other ways to get that information. Also, what I would say is that if at any time you can't find that information, but you reach out to one of ourselves, certainly I know the people around who are doing this or exploring work, but there is that remote option as well. And a lot of the time, what I encourage for patients is I'm very happy to speak with a local physician first, if that's the question. If your physician in Canada or Europe wants to check if this is a suitable option, to help make that decision.
Okay, perfect. We had a couple of questions about whether or not HAI therapy is considered the standard of care in the United States.
Good question. So it's mentioned in the NCCN guidelines. I think increasingly it's being incorporated and recognized. I think it's important to acknowledge that up until recent years, a lot of the data that was coming out around with the pump was retrospective. I think and single institution, as in being from Memorial Sloan Kettering. I think now with the prospective work that's out there, and also work from other centers, such as that study from the Netherlands, as well as we also have now a HAI consortium here in the United States, which is multiple centers around the country. They have a certain number of HAI pumps, so certain high volume centers where we're trying to collaborate and have more prospective trials to help, bring this more to the fore. I do think that, last year at ASCO GI, honestly, there was so much buzz from the presentation that was there, and rightfully so. And there really has been an upsurge in the number of centers doing this. And I think through the consortium and efforts, we're going to see this increasingly being used, and more studies as well, like to answer some of these questions. Well, what about immunotherapy? What about this? And, to answer that. And also the question about liver transplantation.
Can the HAI pump be combined with targeted treatment like Tibsovo?
No, not yet. So again, this is where I think it's a watch this space, and we have to understand and first of all do some safety or pilot work to see how to safely combine many of these agents that are out there. If we look at cholangiocarcinoma in particular, I've used the pump with gemcitabine, oxaliplatin, cisplatin, irinotecan, 5-FU, really are standard drugs. In patients who have actionable mutations, IDH1, FGFR2, I haven't given it concurrently with any of these targeted drugs, but I've certainly had patients who've done very, very well. And again, if it's liver confined, I would reserve these agents for later on in patients. But no, not at the current time.
Okay. Regarding Gilbert syndrome, would you have stats on if there is a high number of patients with intrahepatic cholangiocarcinoma that also have Gilbert syndrome?
So what I would say in that regard is definitely in some of the retrospective work that's out there, there's been some of this quoted. In clinical practice, I would say that the Gilbert syndrome is not a contraindication to having the liver pump put in. It's a very informed discussion with the patient, and watching the trend in terms of what's happening with the bilirubin and that. And I certainly would say, and this is really observational based, that I haven't seen in my own experience any increased complications or side effects or lower responses in those patients to the pump. I think it's equal.
Okay. When loaded, how many cc's are added? The pump volume.
Yeah, so it's a 30 cc. So the pump itself is 30 cc's. And usually for the active drug, it's run at a rate of about 1 cc per day. But it's a 30 cc volume. Mm-hmm.
Okay. Yeah. Can you get local treatment like histotripsy if you have the HAI installed?
Yeah, good question. So yes, you can. So things like, let's say, for example, if I have a patient who has very good control of disease in their liver on the pump and maybe has an isolated metastasis that's growing, right? So everything else in the liver is under control. There's one spot that's resistant. We're not getting it. We can go in and ablate. You can consider histotripsy. Histotripsy we only have here at Memorial in recent months, so I don't have a huge volume of patients to quote on, but I view histotripsy along the same lines of ablation, and I've certainly gone in and ablated patients. I've also had some patients who've had histotripsy done at outside centers before we had it here. I think we got it here in April or late April. So it makes sense in a patient like that, right? If it's an isolated lesion that's growing. If it's a patient who's had very good control in the whole liver, but now you're seeing multiple spots growing, in that patient, I would use the mitomycin instead, though. So again, it comes down to the response that they've had to the FUDR, and also the degree of what's progressing right now. But yes, you can ablate. or do histotripsy.
Okay. Understanding that everyone has different types of insurance, is HAI pump therapy generally accepted by insurance if it is something that a patient is approved for by their medical team?
Yeah, so yes, absolutely. It's not uncommon that we have to write a letter of medical need, but I've not had somebody who has not been able to get this because of insurance. And that applies to patients both nationally here in the United States and also from abroad. And that's why I mentioned earlier, even with embassy support and things like that, we'll often write letters. And I think the data is showing that this helps patients in the right patient population. And once that's explored and explained, and there isn't a local provider available or an expert center close by, I truly have not come to an issue that a patient hasn't gotten it for insurance reasons.
Okay.
Yeah.
When you said the earlier the better, does that mean before completing a full 6 months of the Gemcis Durva?
No, I've definitely done it in patients, for example, who've been on Gemcitabine Durva for 6 months. Maybe they've had some response, but there's some stability there. They're still not operable. Um, I think in general, what I would say is in patients in the earlier phase of treatment, with less chemotherapy exposure to the liver, I've seen that the tolerance of the pump in terms of the dose intensity is higher and also the response rates. I'm more concerned if I see a patient who perhaps is 2 years into treatment or has gone through 2 or 3 lines of treatment with progression in the liver. That certainly would be more concerning. But the patients on Gemcis Durva, honestly now, because if patients are coming to me from the outside, that would be a very common time point that I might see somebody for a second opinion or thinking about a pump, particularly if they don't have some other actionable mutation like IDH1 or whatnot, or they can't be operated on. And what I've done in patients like that, what I would typically do is they've come off the 3 drugs for 6 months is if we agree that a pump is suitable for that patient, I use gemcitabine as the modified systemic chemo. So really patients feel a whole lot better. So the maintenance is gemcitabine basically with the pump, as opposed to if a patient didn't have a pump, they would stay on the immunotherapy.
Okay.
Yeah.
When you say good liver function in labs, can you give us an idea of numbers? Do they all need to stay in the normal range?
No. So again, what I've seen, particularly in patients with cholangiocarcinoma, if there is like a higher volume of disease in the liver, patients can come to me and their alk phos to start with, for example, could be 300, 600, 800. Obviously, I have imaging showing me that, this is disease related and not something that, needs to have an intervention for, but their bilirubin is normal. Let's say it's 0.7, 0.4, or if they've Gilbert's, it's 1.2 or something. But you can have an alk phos of 600, 800 to start with. Whatever the liver enzyme is on the day of the first treatment, that's our starting point. And we follow that going forward in terms of the dosing. If the alk phos, what I often see in patients, particularly with cholangiocarcinoma, is, I mentioned this, is that I begin to see the liver numbers improve. So the alk phos goes from 600 to 400 to 300, even ahead of tumor markers. However, if the bilirubin is increasing, or there's concerns for portal hypertension or ascites, or those would be concerning. But a high alk phos or a high transaminase is not a contraindication if it's related to the cancer itself.
Okay, perfect. I think you can answer this one in the last minute that's left. If having the pump, there is an expectation or chance of shrinkage.
Yes, certainly. What I would say is that what I've seen in patients with cholangiocarcinoma in particular, is that it's very hard to give an exact number, but it'll take several months, right? It's not going to happen straight away. In general, what I've seen for patients is that maybe, it's about 12 months on pump treatment. We begin to see, okay, now we can consider surgery. I have had a handful of patients who get to surgery from pump treatment, or we might move on to something like ablative radiation or consolidative radiation in those patients. But it's usually around a year and a half, I would say. So it's slow and steady, but patients do get there. I certainly don't want to put across that this happens within 3 to 4 months. It definitely takes closer to a year. But I have seen it, and I have had many patients who get chemo breaks, who get, de-escalation of chemo, or we've added in other treatments like radiation or surgery or histotripsy, and then they come off treatment. Yeah.
Great, thank you. I know we are at time. I appreciate you taking the time out of your clinic day to be with us today and talk about the HIA pump. Everyone who's watching, this is being recorded and will be uploaded to the YouTube channel that the foundation has, so you can rewatch it if needed. Thank you again, Dr. Connell.
Thank you, Lourdes. Thank you, everybody. Okay. All right.
Thanks.
Thank you.